So it's time to start this session, live case and lecture 9, TEER live demonstration. So I'm Jung-Sun Kim, Severance Hospital, Yonsei University, South Korea. My co-chair is Shinichi Shirai from Japan. We also several panelists, Kam-Tin Chan, Narathip, Chunhamaneewat, and Daisuke Hachinohe, Joo-Yong Hahn, Geu-Ru, Shunsuke Kubo, Takao Morikawa, Didier Tchetche, and Wojciech, and Junichi Yamaguchi. And let's start from the live demonstration from Taiwan. So can you hear me, Dr.
Yes.
Song?
Yes, Professor Kim.
Yeah, nice to meet you.
Very clear. Nice to meet you. And good afternoon, Professor Kim, and also Shinichi, and also all the experts, all the panelists on the stage. On behalf of Taipei Veteran General Hospital structural team, it's my pleasure to join the lab demo section. So I'm Adam, and also with my colleague, Dr. Tsai, and also Dr. Zhang, I'm on the right-hand side, and also William, our images will provide will guide us to do the procedure. And also we have our anesthesiologist, Dr. Lee. So without further delay, I would ask our Dr. Chen will present the case. Dr. Chen, please.
Hi, good afternoon, everyone. So I'll do the case briefing. So this is a 78-year-old gentleman who experienced progressive exertional dyspnea and orthopnea for 6 months. So reviewing his past history, he has atrial fibrillation, CHA2DS2-VASc score of 3. And he also has hypertension under medication. Of note, he's ex-smoker and quit smoking 15 years ago. So actually, this patient was followed up at outside hospital. Due to severe mitral regurgitation and severe tricuspid regurgitation, surgery was suggested, but the patient was reluctant to receive open heart surgery. So he came to our hospital for a second opinion and asked for evaluation if transcatheter-based intervention is suitable. So for the non-invasive studies, we can see the echocardiography. It's a P3 flail of mitral leaflet coda rupture with severe mitral regurgitation. And the patient also has dilated tricuspid annulus, which resulted in severe secondary tricuspid regurgitation. His LV systolic function is preserved. So for the coronary angiogram, he has patent coronary arteries without obstructive lesion, and there's no problem that we need to attend to. For the right heart catheterization, we can see that the patient has high wedge pressure as well as high pulmonary artery pressure and right atrial pressure. The cardiac output is low at 2 liters per minute, and the PVR is also very high, 15 Wood units. So this is his X-ray. The X-ray and ECG showed atrial fibrillation, and the X-ray showed cardiomegaly with some pleural effusion and pulmonary congestion. So from the TEE, we can appreciate P3 flail with severe mitral regurgitation. The EROA is about 1.1 centimeter square. And this is the 3D, and we can see the flail at the P3 segment. And the MVA by 3D planimetry is 7.6, so we don't need to worry about the mitral valve area. So as for the tricuspid regurgitation, we can see annual dilatation with severe functional TR, and the morphology of his tricuspid valve is type 1 with 3 leaflets. So in this patient, this is a concomitant case of mitral valve and tricuspid valve TEER procedure. So for the mitral valve, we are going to attend the P3 flail, probably with an XT or XTW clip. And for the tricuspid valve, we are going to do the anterior septal leaflet clipping with 1 to 2 XT tri-clip. It's a zipping method. and also another clip at the posterior septal leaflet of the tricuspid valve with XTW. It's a cover technique. So before the procedure, we're going to do cardioversion in this patient, and we need to be aware that because of the high PA pressure and the RA pressure, maybe after the guiding catheter retrieval to the right atrium, we might face with bidirectional or right to left shunt in this patient. So the teaching point today is a concomitant TEER procedure for mitral and tricuspid regurgitation. And today we're going to demonstrate the use of tri-clip dedicated steerable guiding catheter used in mitral valve TEER procedure. So the mitral valve TEER procedure is the non-central primary regurgitation. And for the tricuspid TEER is the severe tricuspid regurgitation secondary to annular dilatation. Thank you.
Thank you.
Yes.
Very interesting case. So, is there any question or comment from the panelists?
Yeah.
No? Is it a usual situation to perform the concomitant procedure, both MR and TR?
No, it's not. Given a pre-procedure right heart cath relation demonstrating that the patient have high elevated LA pressure and also pre-existing high eye pressure. So according to our previous, I believe we all have the similar experience that after the mitral TEER procedure, if the patient with very high eye pressure or have more than severe tricuspid regurgitation, there might be right to left shunt after the procedure, and also will confronting the post-procedure care. So especially according to what we have learned from the surgeon, and given the patient with severe MR and also dilated tricuspid annulus, majority the surgeon will actually do the concomitant procedure. So today we are thinking about if after the mitral TEER procedure, if we did have right to left shunt, we will do the concomitant procedure. In order to do that, therefore we need to use the tri-clip guide for the procedure. So this is from the, later on we can see the fluoro image, you can show the show tip guide, which is the tricuspid guide. And so on top of the baseline, the images before procedure, today actually we saw that the MR actually even worse after, today, after anesthesia. So William will show you, now we have the images.
So just to report the imagery we have today. And this four-chamber view, you can see some pericardial effusion pre-existing, which is very important before we start any procedure. And this is the bicommission view, and showing the flash segment become, I think it's become larger. And it's very important to identify from this view to check the flow convergence. You can see some flow convergence over the lateral indentation and the central part. So before we examine the pathology in detail, we have to examine the minor lesion first, because it's very important. Sometimes there's lots of color. After we fix the pathology, we saw some color flow jet, but actually it's pre-existing, but it's just obscured by the main pathology. So we examine the central lesion. There's a well coaptation, even though the annulus is a little bit dilated, and also see the central part. And this is the main target, and we saw that there is some more coded-like structure and some jet lesion, probably jet lesion over the anterior mitral leaflet, which is not presented a month ago. And we examine in detail. So we recheck the patients, the lab data showing there's no any sign or possibility of infected endocarditis, but we definitely know that the leaflet characteristic of leaflets sometimes will be a little bit fragile. And we see we examine the pathology in detail. We saw that the large prolapse segment, and this is the 3D. This 3D color, which is showing that. Another important thing is we always check the pulmonary vein systolic reversal, but for this particular case, if you see the, I can explain that later. And we examine the tricuspid valve. It's annulus dilatation, But luckily, the TR actually gets some improvement. We see some just moderate degree of TR. And we have a very beautiful transgastric view showing that it's a type 1 morphology. And this is the procedure. And maybe I can show you the pathology. Just mention that because this jet is directly to the left atrial appendage, so you won't see a systolic flow reversal in the pulmonary vein, but you will see the systolic reversal over the appendage. So that will be our target indicator for the procedure success. And after that, we do the uncut MPR, multi-plane reconstruction. And we can see, I think this will be our main target for the grasping. And Dr. Song has already performed the transeptal. I'll just show you quickly. You see the transeptal puncture, the height is 4.4 centimeter. And we have a guided inside. So this is the situation we have.
So now you know the situation that just wonder what would you prefer? What would your preference clip size for the pathology?
Oh, sorry. Dr. Song, can I ask you a question? This
Sure.
Chen from Hong Kong. You know, the primary pathology is a severe MR, and the TR, although severe, is a secondary or functional sort of TR. So is it a logical approach to just do the MR, you know, the clip of the MR, see the reduction of the MR, and then wait and see, you know, follow up the patient with serial echo TEE, because there will be time for the RV to remodel, and then we would expect the TR to be, you know, reduced in several months' time. So can I, you know, stage the procedures, and then do the MR first, and then send the patients for monitoring with serial echo to decide whether we will do the TEER for the tricuspid valve, or whether you would like to do it simultaneously at the same time. What is your view on that sort of approach?
Yes, thank you, Professor Chen. That is also our original plan before the right heart catheterization. Majority of the patient with concomitant tricuspid and also mitral valve disease, I would prefer stage procedure. But after the right heart catheterization, which indicates that the patient have high RA pressure. In our previous experience, that patient might encounter right to left shunt. Some would have very severe right to left shunt and with a desaturation. And also the other point is that the patient actually have combined, mixed combined pre and post-capillary pulmonary hypertension. For those patients with isolated post-capillary pulmonary hypertension, majority of TR would gone after the procedure. But for patients with combined pre-post-capillary pulmonary hypertension, a majority of them will remain, have progressive tricuspid regurgitation. So that is the point where we, for this patient who has elevated high eye pressure and also combined pre-post-capillary pulmonary hypertension. So for this particular, the 2 points, I therefore prefer, maybe we need to do the concomitant procedure.
Hi, Adam. This is Kubo. So
Hi, Kubo.
Hi, thank you for the beautiful image. So I agree that the target of I think that the lateral P3, this is the huge flare part. But in the 3D image, you can see all the P3 part is actually separated. So you can see the lateral P3 part. So it seems a little bit the prolapse. So if we put the XCW in the lateral P3, it's going to be some residual MR from the medial to the clip. So how do you think about that?
Yes, that is very good point. So before the procedure, actually we have evaluated the lesion close to the commissure, which showing that only prolapse, but without significant regurgitation. And the majority of the regurgitation is coming from the lateral P3. So I think the long clip would able to, if we are able to grasp the majority, because the posterior blade is just 13 to 14 millimeter. So if we can have 12 inside the long clip, we are able to have some sort of annuloplasty And therefore, the commercial, the jet, the adjacent jet at the medial side would be, I believe, would be disappeared.
Okay.
So at the first beginning, actually, I prefer to have ST at the lateral or medial pathology because there are numerous coded which are not able to seen in the images. But we see the quality of the posterior lip. They are heterogeneous echogeneity. So I am worried that if we apply ST, we probably we get too much lip tension. Too much tension on the lip, which may tear the lip. So we decided to have a wide clip, but which might also increase the difficulty in targeting this part, this pathology.
So go ahead. Yeah.
So I am now waiting. We will use show axis, which we always use the same. And then we are illustrator, and we will give us the tip of the clip.
Yes, you have already beneath the
So we can
ridge. So you are
gently steal our clip and readjust.
Do you usually do the procedure in RAO view, in the fluoroscopy, or just AP?
Nowadays we use the IO 20 degree.
Oh.
Yeah, which would give us a better, full chamber view from the fluoro image. We can already have some sort of the full chamber view. And now we have been, toward the apex. And in this view, if we are, overlap the clip on, actually we can have a 6 to 12 o'clock orientation. So which would also facilitate our procedure. So now we rotate from the amplifier image, enlarged image. So we are now overlapping. So reading will give us the very precise bicommissure view, and then we can check the trajectory. So it seems that the trajectory should be fine for this position. We are perpendicular to the mitral annulus. So if the trajectory is fine, now we can open the clip. Open. And then we can check the orientation.
So would you resume again your strategy? Would you start more medial with the aim of being more central with the second clip, or would you start directly exactly at that target and aiming at one clip? Because I have the feeling that maybe two clip strategy is going to be the optimal solution just to solve the mechanism.
Yes, Didier, you are right. So, but I think before the evaluation, we saw the gap medial to the pathology is quite small, and also the posterior blade is not really lengthy. So maybe I'm thinking if we have a long clip to have adequate lip blade insertion, we probably are able, to have some annuloplasty effect, and therefore the jet might all gone. So I would, at the first beginning, try to target the pathology just lateral P3, and then to see whether or not if I can have to change the strategy. I'll move the clip. But if we use a long clip, I would prefer have a short clip. So which would depends on, after the trial, the first attempt. And what we have shown that when we have overlap on the IO 20 degree, we almost have 6 to 12 o'clock, so which might easier to facilitate the orientation. So now you can see that we have a rotation a bit less than 12 o'clock, which may, would be, I think, would be, suitable for this lateral P3 pathology. So within, can we have a 2D by commercial view? And now we have to identify the grasping view. So within will rotate, very gently rotate the X-plane. And on the right-hand side, you can see the arm wide opening. So we will confirm the gripper. So, okay. So anterior posterior. And then we will close the clip. And then to see the pathology again. So you can see that just beneath the clip, we saw the flare. So this is what we need, and also we are going to treat. So cancel the color. So we have both
Adam?
and also, yes.
Do you try to implant the clip a little bit counterclock orientation, right?
Yes, a bit.
Okay. Little bit
counterclockwise.
Okay.
Yes, we can show the 3D image again to see whether we can have,
Yes.
So that's why
because it's 35 degrees, so it's a little bit counter as comparing to the 6 to 12 o'clock. Yeah. Maybe.
So Takashi, what do you think? Takashi?
Okay, I'm Takao instead of Takashi. Hey, Adam, do you know? So, is this angle for preparing for second clip, or just because of the mitral regurgitation direction?
Yes, I hope I can have a one clip to finish the procedure.
Mm-hmm.
So this is our orientation that aim to
This is orientation is for the direction of the regurgitation, right?
Yes.
Okay.
Yeah. Yes. Of course. For the lateral P3. So we can have 2D again, and then we will show grasping. No, the arm is not. We need advance the T-probe a bit. Okay, and explain. Okay, we saw very clear of the arm. Okay, close. Okay, perfect. So we also see, the flare just beneath the clip. So in order to have a very, precise descent to the left ventricle, I will also ask our anesthesia to reduce the type of one a bit sometime. And then we should, we have, more precisely descent, because we know there are numerous coded at a P3 region, medial segment. So we hope that we can, descend into the right position. So we saw the flare, so which may suggest that we are at the right position. Okay, we already descend beyond the leaflet, so we can open now. Open. 30 degrees. We did not see the two arms. Oh, later. So we have anterior, but within. Can we show the both arms?
Yes, but you have some rotation.
Yeah.
Oh, I see that.
Yes.
Yeah.
But I think maybe the rotation is correct, because
Okay. Can you have a 3D?
We can check the 3D. Yes.
Okay, you can give us 3D first.
Sure.
No, too much.
A little bit too much.
Okay, we close. Okay, give us 2D.
Okay.
I think if we are not able to, to modify the clip arm, Okay. See the orientation again.
Okay.
More.
Yeah, maybe it's too much counterclockwise.
Yes, I still need a bit. Can you reduce
2D
again?
again?
Reduce again.
Reduce
Further.
again.
Yeah, probably almost. I just need
Just
a
a
bit,
bit. Yeah, just a
clockwise.
bit. I think it's okay.
2D. So we usually, I don't, prefer to do the orientation, rotation inside the left ventricle. But the tip is that you have to do it very slowly. And also do not open the clip too much. Okay, William, can you show us
Orientation again.
orientation
Sure.
again? Now we have flare leaflet. Just we rotate and we recheck and then to confirm. So what do you think, Didier?
I think it's
So I
better.
think it's
We still
if
need
we
some.
aim at putting a second clip, I would slightly withdraw a bit of counterclockwise rotation, but just
Sure. Okay. I think the orientation might increase again. We see the leaflet cooptation. Yeah, I think the leaflet
Yeah.
cooptation probably is fine. So can you give us 2D again? I would have also have a bit gentle rotate. Not too open, too much.
Now the clip seemed to move more medially. And it looked in this 3D that the flail is a little bit more to the medial
Yes.
from the clip.
Yeah. William, can you show us the 3D again?
that's good.
I think should be fine
I think it
for
should be
this
fine. I
position.
think it's okay.
Yeah,
Okay,
it's-
so we are now going to have the grasping. But our anterior now is not really sitting inside. So I will go a bit.
Yes.
Okay, yes.
Yeah, it's better.
Definitely.
It was curling
Perfect.
before.
So now I will go a bit posterior.
Yeah.
Okay, gripper down. And close. 220. Close, close. Gently. Okay, to 6. Okay, it's fine. And before we fully close, I'll ask William
Yes.
to check, is there any passage left untreated, ungrabbed in medial or lateral to the clip?
I think immediately you close the clip, there's a significant smoke.
Yes, just
Yes.
explain.
Yes,
Yeah,
this
a
is
central jet. So we still have just close at 30 degrees. So we are now, given that we don't have medial jet, so we are now gently close. William, can you give us the explain again?
sure.
So close. Perfect.
Yes. Okay. So are you fully closed?
Yes.
Okay.
Now I'm
so-
fully close.
Okay, I will check the 3D.
Can you check color?
I will check the 3D and 3D color
Sure.
here.
And this was a very nice grasp because you were very gentle with the leaflets, and it's key to prevent any tear, because if you need to reposition, you have to make sure that you are not too aggressive for the first attempt.
Yes.
So it was a
I
very
think
nice
there's
demonstration.
yeah.
Yeah. Didier, you point a very important tip.
And also, this is what we mentioned before. Because we extend the color jet before the procedure, we know that there's some indentation over the lateral, some color jet from the lateral indentation, as well as the central segment, but it's just a mild degree. So the most important thing is are we still have some medial lesion? But I think from the color and the by cognition view, we cannot see any pathology or just a very trivial MR medial to the clip.
I think it's very nice because so primary portion jet already diminished. Yeah.
Yes.
This looks really nice. But
Yeah.
I think sometimes one question is sometimes we have some combined pathology, primary and secondary.
Yes.
Then if that kind of situation, what is the first to
Of course.
to fix? Yeah.
The DMR, degenerative pathology, would be the first one to get treatment. So especially when you use the long arm clip, we probably are able to have annuloplasty effect. So the functional part might also be improved.
Well, also
So
since you're using the TriClip CDS, the delivery system, the TriClip for the mitral clip. So is there any tips and tricks? Are the knobs, or the movement maneuver the same as using a mitral clip CDS? Do we have any tips and tricks of?
Actually, it's the same, but by using the tri-guide, the punctual height, the requirement of the punctual height might be less than using the mitral clip. But also, yes, and also that would be less. Sometimes would be less out of heart position. So actually, it would be some kind of important trick. If you are going to treat a patient with acute mitral regurgitation, my personal belief in that the tri-guide might be even more suitable than mitral guide.
Because it's much shorter. Yeah, am I right?
Yes.
Shorter, yeah.
Yes.
I have a question.
So,
Okay.
yes.
Yeah, I have a question. Okay. Can
Sure.
I have a question? Okay. So, if your mitral clip procedure is quite really successful, but if you remove the SCC, there is no RL shunt, and only left to right shunt. It is very nice. But this patient is a severe thoracic regurgitation. So if the RL shunt, the TriClip is very reasonable, but there is no RL shunt. Do you decide to undergo TriClip or not?
I don't know. Actually, I need your guys' opinion from yours. So if I have right to left shunt, some majority of patients actually after extubation, because the PIP after extubation or given some minutes, maybe 10, 20 minutes, the shunt would improved. Right to left shunt would be improved. But for this patient, the patient had elevated very high PVR related to long-term chronic severe MR and also pulmonary combined pre-post pulmonary hypertension. I just wonder, maybe the long-term, in the long run, the TR would progress eventually. So I just thinking about if the surgeon would do the concurrent procedure, and if I know the procedure would be for tri-guide, whether or not we do it, immediately or after the procedure to do the stage would still be very safe. So I actually don't know. But if I saw right to left shunt, I would go for TriClip. And if I remain see severe TR, I would go for TriClip. And because of combined proposed capillary pulmonary hypertension. That is my original plan.
Dr. Song, I'm Geu-Ru from Severance Hospital. Nice to see you. Yes.
Good to see you.
Actually, this patient have two pathology in the atrial functional MR, in the lateral portion and the central portion, and the severe primary MR in the medial portion, right?
Yes.
So I think this patient has long-standing atrial fibrillation.
Yes.
And the long-standing atrial functional MR.
Yeah.
And recently he had a coded rupture and had a severe primary, very big PISA, the very severe MR. So I think basically he have a, the atrial function MR and caused by pulmonary hypertension. The some degree. But this is the added, primary MR is worsen the pulmonary hypertension. So, but you fixed only the primary MR. You will leave it in the atrial function MR, right?
Yeah.
So I think, in my opinion, you'd better see without any tricuspid clip. So you can, you eliminated primary MR, just that he had in the atrial function MR. So maybe his pulmonary hypertension can be, improved after mitral clip in the primary MR.
Yes, that is also a very important point. In order to, improve the atrium function, the functional MR part, we also do cardioverse. So you can see that from the ECG, the heart rate is very regular. That is also my, another trick to do the procedure, another tip to do the procedure, because when you have a atrial fibrillation and rapid heart rate, you would have, impaired image quality, and also maybe, even more difficult to grasp the leaflet. So before the procedure, we usually, all the cases, we would try to do the cardiovert the patient and to try to restore the reason. If if the reason can be restored to be sinus, the image quality actually would be better, and also the grasping would be much easier and to facilitate the whole procedure. So that is also another trick. So that is, maybe we can, after the procedure, if the patient can stay in sinus reason, in the long run, the TR and also the functional part would not get a progression.
So, yeah, go ahead. Because sometimes it leads the clip, the mitral regurgitation, tend to increase. Yeah, so I think
so
we
just
have to check again
check
after
the
leads
leaflet insertion.
clip.
I think it's quite lengthy within the clip, and there is a significant disappearance of the appendage flow systolic flow reversal, and the mean pressure gradient is fine. It's just so I totally agree with this clip, the position and the grasping. So I suggest that we can deploy the clip.
So Dr. Kim, you are right. Your point is a good point, because especially in the medial part of the first clip, sometimes we underestimate the residual MR because there is a shaft shadow. So,
yes, totally agree. Yeah, so it's very important. Sometimes, if you want to get rid of the shadow, you can adjust you can insert the tip further, the probe further, and you're going to see the medial segment more clearly. And you will not obscure by the shaft. We don't see any MR. Yeah.
So while the team is releasing the clip, just to provide another perspective, because there is the Pascal device that is also available, and I have to say that for these concomitant procedures, it's perfectly suited, because with the same delivery system, the same setting, same setup, you can treat both the mitral and the tricuspid. It's just the way you orient the fin that is different. But it's a very easy solution for combined strategies. And personally, I would continue, go on and treat the tricuspid regurgitation in that case, because we know that there is an adverse impact of TR, residual TR, moderate to severe. So I would do it all for the patient.
So we are going to release. So very stable.
Very nice. Yeah.
Yeah. Do you think we need to, treat the atrial function MR? William, can you show the 3D image and also the color?
You want to?
Yeah, we just need the panels to.
Yeah, I mean, maybe you can just.
Okay.
Withdraw the.
So can you give me the guy?
Yes, sure.
The guy in the.
Sure.
Okay, sure.
Okay.
Okay, can you show that
Yes, sure.
residual more?
Very nice. Oh.
Adam? So
Yes.
I think that this is a perfect result of this kind of the pathology. But I think that sometimes the operator difficult to get the posterior reflex. So in this case, because the flare is very huge, so when do you consider the CGA system in this in the grasping of the flare reflex?
So what do you mean the CGA system?
Yeah. When
Yes,
do you
that
consider?
is true.
Yeah.
Yes, you are, of course, the control gripper activation, sure. But you see that before we, lower the gripper, we already have the, the posterior liver very clearly. So if we don't have very good image, I will use that. So in majority of our case, actually, less than 3% we will use the function. And majority because I have William, he can show me the very best image to improve the image, and then I can understand how much liver I can have. And also we now are measuring the LA pressure. If you can see that before the procedure, the V wave is 37, and now the V wave is 18, and before the procedure, the A wave is 22. And now the A wave remains 22, but the V wave is 18. So we got the mean LA pressure from 24 to now is 20. So we got a good improvement in the LA pressure and also MR severity. So now we need your suggestion whether we need to go for tricuspid clipping.
How is the right atrial pressure now? Is there
Right
any gap?
atrial pressure.
Is there any gap?
I don't. And CVP level is 17 to 18.
18. Oh, too high.
Yeah, CVP level. But it's not right atrium level. So I can pull back the caster to see whether or not we have the shunt issue. So I think we all agree that we don't need to treat the mitral position. Right?
Yeah.
Yes. So I will move. Let's click the CDS. William, can you show me the SS view? And then we can see the jet. Or William, you can also show in the TR. It's fine. It's fine.
Check again.
Okay,
procedure.
fine. William can always get a good image, so don't worry about him. So I will put back.
Oh, should be treated.
So it did have right to left shunt.
Yeah.
That is why, before the procedure, we already thinking that might occur. It's bidirectional.
Yeah.
Bidirectional, yeah.
How is the saturation now? It's going
Now
down?
not yet. It's now remain 100%, but we have FiO2 of 100%.
Oh.
So can you reduce FiO2 to 50 or 30 to see whether it would have desaturation? But I think majority are the shunt is from left side, but we still have some right to left shunt. So William, can you show us the TR? The ENFACE view or the TR first?
First view.
Yeah, we have probably moderate.
Yes, probably moderate.
So actually, in Japan, now we cannot use tri-clip, and so in such case, we give this patient nitro.
Yes.
Nitro to reduce the PA pressure and RA pressure.
Mm-hmm. Yes. We also give the patient after the procedure, or majority, more than 80% of patients, we will give nitrite after the procedure. 1 day after the procedure, when they stay in the recovery room. So any suggestion?
very difficult.
So
to
you-
decide
So,
it. I
so
think it's,
I'm Narathip from Thailand. Our situation, in our country, it is not reimbursable. So I think almost all of my patients, I would do just mitral TEER and then wait to see what happened, because when patients have to pay off pocket, I try to be conservative. I think, in this case, I would wait for like 5 to 10 minutes. I think if the patient does not have desaturation, I think I would leave him alone today and call it a big winner with one clip. I think we got the excellent result for M-tier.
Yes, I have the same, actually same idea, because the mitral clip and also the triclip are now reimbursed in Taiwan. So it all depends on patient's decision. So it actually is the patient, majority patient who are able to, afford the cost. They would usually like to have concurrent procedure. They are thinking about maybe they don't want second times of general anesthesia. But before the procedure, I always would, convince them. Some are not able to do the tricuspid procedure after successful mitral clip, mitral TEER procedure. But it is especially for those patients with isolated postcavity pulmonary hypertension. So again, this is a condition that I don't really, sure whether the TR would get improvement gradually later on or with the patient. But I have to do my best. I restore the sign of reason and hope the patient can stay in sign of reason. If the AF did not recur, I also believe that would be, the TR might not, worse later on.
And another option, if it's not reimbursed, is to use the same delivery system. You use the mitral clip system, and you just modify the key 90 degrees, and then you can use the same system, and you have two additional clips that you could use for the tricuspid.
Yes, that also what we have done in the past days. But today we select the tri-guide. So in order that if we need to do the tricuspid procedure.
So is there any difficulty to use that kind of system for the mitral clip procedure with the tri-clip delivery system? No, just the same one or?
The same, even better, because what I have said is that the requirement of the height would be less than mitral clip, because the guide tip is shorter with the tri-guide rather than the mitral guide.
So what is your plan? Just finish the procedure or?
Yeah, our plan is that.
Prepare.
Yeah, we have discussion with the patient. Actually, we have prepared. We have prepared the guide because the patient before the procedure, he asked us, to try to, make sure he would not need the second GA procedure. Okay, sure.
Excuse me, can I
Sure,
have
sure.
a question?
Counter.
Sorry, can I have a question?
Counter.
yes.
Go ahead.
Can I have a
Yes,
question?
please.
Okay. For the patient, about the tricuspid treatment, for the patient already have pulmonary hypertension and high pulmonary vascular resistance, would you worry about the afterload mismatch in this patient after you close the tricuspid regurgitation? Thank you.
Yes. I think it depends on the etiology of pulmonary hypertension, of high PV resistance. If the patient have high PV resistance related to the left heart disease, according to the published data, majority of them would get improvement. Only for patients who have very depressed RV function, I think the abolish of TR might not be very suitable. But before the procedure for this patient, we have echo-derived peer pressures demonstrated high peer pressure. We also have invasive data showing that the patient have high peer pressure related to the left side. The patient did not have lung disease-related pulmonary hypertension. The patient is not group 1 pulmonary artery hypertension. So I think the increase of PA pressure resistance could be related to long-term, left heart disease, including atrial fibrillation and also the mitral regurgitation.
So Dr. Song, it's time
Yes.
to give a lecture. So you already recorded the
Yes.
lecture, is right?
Yes.
So
yes.
after lecture, and then I think if possible, after the another Asan live case, and then we will come back to see your last results. Is okay?
Sure.
Yeah.
Yeah, of course. Thank you.
So next one is we have a time to give a lecture that by Shih-Hsien. He already recorded lecture. Please.
Thanks the organization committee to have me in 2024 TCTAP. I'm Shih-Hsien from Taipei Veteran General Hospital. It's my pleasure to join this live demo section. And this is my disclosure slide. Since we already have the TEER technology to treat mitral valve disease, nowadays is that TEER ready to become the mainstream in the treatment of mitral valve disease? The answer should be stratified based on two distinct etiologies of mitral regurgitation, the primary and secondary mitral regurgitation. The answer for secondary mitral regurgitation should have been very clear, since the COP trial has demonstrated persistent clinical benefit with TEER procedure during a 5-year follow-up duration. On top of GDMT, TEER may reduce failure hospitalization, as well as improve long-term survival among patients with heart failure and moderate to severe functional mitral regurgitation. Therefore, the ACCH a heart failure guideline in 2022 has recommended TEER for patients who still have severe symptomatic functional MR after GDMT, if the mitral anatomy fulfills with the inclusion criteria of COP trial. As for degenerative mitral regurgitation, we all agree surgical mitral valve repair nowadays is the standard treatment, since half century ago, Professor Comitier has proposed French correction for mitral regurgitation. Although there was no randomized control study to compare mitral valve repair versus replacement, the observational study have shown the survival advantage of mitral valve repair over replacement. More importantly, mitral valve repair may restore the lifespan of these patients to that of the age sex-matched US population. The data from International Mitral Regurgitation Database further confirm the survival advantage of mitral valve repair over replacement by matching analysis or IPW adjustment cohort. Therefore, the guideline has suggested in patients with suitable anatomy for mitral valve repair, mitral valve replacement should not be performed. However, the repair rate was positively related to the hospital annual volume of mitral valve surgery. This is data from STS surgery database of more than 1,000 hospitals and more than 55,000 patients with DMR. Unless the patient was treated in a hospital of the top quartile mitral valve surgery volume, more than 25% of the patient would eventually undergo mitral valve replacement. Even majority of surgery were done with sternotomy. So what about the durability of mitral valve repair in a high volume center? The CTSN clinical trial to evaluate the clinical benefit of concomitant tricuspid valve surgery in patients with DMR and moderate TR. You may appreciate the 90% repair rate in these experienced centers. During the follow-up of 2 years, there would be 15% of MR recurrence or mortality. Specifically, there was 8 to 10% recurrence of moderate to severe MR at 2 years. The only evidence to compare TEER with mitral valve surgery for patients with DMR was from average to trial, which recruit patients with majority DMR. Although the 5-year survival rate was the same between TEER and mitral valve surgery, TEER was associated with 20% excessive risk of redo mitral valve repair surgery. So we all know that at the 6 months landmark analysis, the mortality mitral valve surgery and reoperation rate was the same. However, therefore, it was not due to a recurrence MR, but due to the inferior immediate result with TEER procedure compared with surgery. Both before discharge, 23% of the TEER group remain have more than 3+ MR, who later underwent mitral valve surgery. For patients who had successful procedures, the recurrence of mitral regurgitation equal or more than 3+ was the same between the two groups. What if we could improve the immediate TEER result along with the advancement in device technology and the improvement in physicians' experience? That is what we have now in expansion for registry. 97% of the patients have less than 2+ MI 30 days, and the result is durable in 1 year among patients with DMR, regardless of whether the mitral anatomy is complex or not. On the right-hand side, for patients with complex anatomy, the TEER were able to reduce MR to achieve more than 95% than less than 2+ MR. Therefore, the repair MR trial will compare the updated TEER technology versus mitral valve repair for patients with DMR and low to intermediate surgical risk. Before the result is available, the reality is that the TEER procedure has outnumbered mitral valve repair among Medicare beneficiaries, even before FDA expanding its approval for treating FMR in 2019. So the ratio of case number was greater in the elder population. When patients were ineligible for TEER procedure and referred for transcatheter mitral valve replacement in Global Choice MI registry, only 30% of them was eligible for transcatheter mitral valve replacement. The remaining 70% TMVR ineligible subjects were then referred for bare-out TEER procedure, mitral valve surgery, and conservative medical therapy. When TMVR on the left-hand side and mitral valve surgery on the middle very effectively reduce MR to almost 100% of them to less than equal or less than 1+ MR. The bare-out TEER procedure may achieve equal or less than 2+ MR in only 18 to 85% of the patients. Of course, for patients receiving medical therapy, less than 10% of them would have equal or less than 2+ MR at a year. However, the 1-year mortality rate was highest among patients receiving medical therapy, which was 47.9%, followed by mitral valve surgery, 42.9%, and TMVR, 39.2%. The 1-year mortality rate was lowest in patients receiving bare-out TEER procedure, suggesting the excellent safety profile of TEER, and every reduction in mitral registration can get benefit for the patient. We have witnessed that with the improvement of TEER devices and accumulation of physicians' experience, the rate of post-procedure residual MR equal less than 1 plus has increased from 40% to 90% from average try to expenditure for registry. And so did a 1-year mortality rate, which was reduced from 20% in average try to 8 to 12% in expenditure for registry in functional MR and DMR patients, respectively. And therefore is still ready to become mainstream in the treatment of mitral valve disease. My personal belief in that we are on the way. So my conclusion is that TEER is an incredible safe procedure in expenditure for registry, very low 30-day mortality, which was 1.3%, and very low 1-year mortality, which was 8 to 12%, depends on the etiology. And the co-op trial data up to 5 years have shown consistent clinical benefit with TEER procedure. And when pursuing post-M TEER residual MR equal less than 1%, 1 plus is encouraged, the result of the repair MR trial is expected. And thank you for listening. Thank you.
Okay, so now move on to the Asan Medical Center's MTR live demonstrations. Good afternoon, everyone. So are you ready?
Yes, we are ready. Yes, I'm Dr. Kang. Here is the Asan Medical Center, and I enjoy the Dr. Song's fantastic case that ongoing. And during that, we also had some hard time struggling with septal puncture. I will discuss later. And here's our team: Professor Jin-Ho Lee from Kyung-Hee University, and Dr. An Soo-yeon from our senior interventional fellow, and Professor Dae-Hee Kim, our imaging specialist. And Dr. An, can you please present our case?
Yes. We have a 79-year-old man with a history of ischemic heart failure. He was admitted for worsening dyspnea of NIH class 2. The echocardiography shows severe functional mitral regurgitation with moderate LV dysfunction. Transcatheter edge-to-edge repair was planned for severe functional MR. The patient had a surgery for triple vessel disease, CABG, MACE operation, and LA appendage resection in 1998. And the cardiac grafts were Lima to LED, saphenous vein graft to diagonal branch, the first OM and second OM, and the postlateral branch. Next. And the patient has diabetes, hypertension, hyperlipidemia, paroxysmal AFib, CKD of grade 3, gout, hypothyroidism. And he was on guideline-directed optimal medical therapy, including Entresto, beta blocker, and SGLT2 inhibitor. Next. Electrocardiogram shows sinus rhythm of heart rate of 60 beats per minute, and there's a low voltage R wave in the limb-lid. Next. Chest X-ray show pleural effusion on the right side of the heart. Next. And coronary CT angiography shows patent cardiac grafts with good distal runoff. Next.
And cardiac MR, we also checked that that showed the transmural infarction in the RCA territory. So we checked the echo. Again.
The problem is the movie clip is not working in the real world. That it works. In number one image in personal long X view, you can clearly see the wall mobility in mid-posterior with papillary dysfunction, tethered posterior mitral leaflet. In number 2 image, you can clearly see the significant mitral regurgitation. In number 3, you can clearly see the regional homogeneity around the posteromedial papillary muscle, inferior septal, posterior, inferior, indicating the ischemic MR. The LV dilate at 47/61 millimeter, ejection fraction was 37%, area volume index was 54. Next. Previous slide.
Minus.
Yeah, the movie clip is not working, please. Play again. Yeah, but in number 1, number 2, number 3, the yellow arrow indicates the territory of regional wall mobility. The inferior septal wall and base to mid inferior wall and mid posterior was not moved well. In corresponding 4-chamber, 2-chamber, 3-chamber images, and you can clearly see the significant MR at least moderate. Next, please. Previous, please. Yeah, number 1 is not working. Yeah, you can clearly see the RV dysfunction.
Minus, please.
Minus.
Yep.
You can clearly see the RV dysfunction. The TRV max is 3.8. The IBC plethora indicating severe pulmonary tension. The patient with RV dysfunction, it is very problematic for aggressive volume reduction, especially in patients such a patient. Next. Let's move to T images. You can clearly see significant mitral jet. The pizza radius just 6.5, but this is not moderate. In by commissioner view, you can clearly see diffuse MR jet and the right purple band reversed and left purple reversed, indicating severe functional MR. Next. In 3D view, you can clearly see the coaptation gap in the central region and corresponding color flow imaging. The mitral bay was 5.0 square centimeter, and 3D vena constricted area indicated 0.67 square centimeter, indicated severe MR. Posterior implant length 17 millimeter, and coaptation length was 9 millimeter, and coaptation and depth was 9. Coaptation length was 2.5, indicating feasible for mitral clip. We initially planned the 2 clip straight. Thank you.
Yes. In summary, the 78-year-old male patient that have received KBG plus MAGE 28 years ago, and he had a long history of the heart failure with the ejection fraction about 30 to 40%. And recently, for several years, he had worsening of the functional mitral regurgitation and has some history of the recurrent admission to other hospitals. So the patient took the full medication for the heart failure. However, because of the CKD and low blood pressure, they could not maximize the GDMT and referred for the mitral clip to our center. And after this TTE and TEE imaging, we hospitalized the patient and we administered the dopamine with the IV Lasix and decreased the body weight about 4 kilograms. And his creatinine was raised a bit, but we did the gentle volume reduction for the procedure. And can you please some comment or the opinion for this patient? Is the TEER appropriate for this patient, or do we need more before the procedure?
Okay, thank you for your very nice introduction. So, do you have any comments and questions about this case? Okay.
Yes, I'm Geu-Ru from Severance Hospital. Basically, this patient has 2 functional MR components. One is the tethering due to the dilated left ventricle, and the second one is ischemic MR due to the posterior leaflet in the limitation of the motion. So I appreciate in a very wide in a pizza from the medial to lateral. So you want to pick use the 2 clip, right? The wide one. But this patient's mitral valve area is relatively small. It's about MVA is 5 square centimeter. So you want to use the XT, 2 XT or 1 XTW and XT?
Usually what we plan to one XT double clip in the central medial region because the tethering of the posterior papillary muscle is severe. After then, we apply XT or something. We initial plan was that step.
Yes,
Our initial, yeah.
one more thing is about pulmonary hypertension. And Dr. Sung's case have a pre and post capillary severe pulmonary hypertension. But this patient also have a severe pulmonary hypertension. So did you check in the cardiac cath for the PVR and the?
Yeah, but I agree your comment. But almost 30% of hyperactive patients had elevated PVR. But and follow back just 2 days before, we identified the decrease in pulmonary pressure. Almost the TRV max was 3.4. So we did not perform cardiac cath.
Okay.
Yes, we also followed the TE after the volume reduction and checked confirmed the reduction of the pulmonary hypertension. So we did not do that. And thank you for your opinion. And we are now planning the XTW for the maximally regurgitation area, and then we will evaluate the patient and we'll prepare the next procedure or not. And what I said that we had a hard time is about the septal puncture. Because the patient underwent MAGE and cardiac surgery 26 years ago, it was not easy to find a good septal puncture position and septal puncture. And can you please show us the septal, the images that we have taken during the septal puncture?
Yeah, septal puncture height was 4.3. And then very hard to puncture because of the fibrotic septum.
Because there was severe fibrosis, we could not identify the good tenting. So I changed the needle shape, and finally I used the BB1 needle, and with some more shaping, and we could find the septal puncture position. And next, and then it was not punctured with the needle, so I used the radio frequency with the BOV, and then hardly passed the region of the septum. And then we tried to cross the SGC, but it did not pass. So next, so we have done the ballooning of the septum with the 10 millimeter diameter balloon. Next one, it was in LA, and there was some indentation, and but without strong resistance, it was dilated. After that, we could pass the septum with SGC. Yeah, this is the image. So now we are here. We had some hard time find good septal puncture position and advancing the septum. And I want to ask the experienced, the expert panelists about the hard septal puncture after the surgery patient or the long-standing the MR patient. And can you please share your tips and tricks in this situation?
Yeah, so this is Kubo. Hi, do you?
Yeah, nice to see you.
Yeah, I think that yes, I always do the same way. So in Japan, officially the RF needle is approved, so reimbursed. So I think all hospitals use RF needle, and we use larger bended RF needle in the hard septum. And also that if we can't cross the guide catheter or the SLCs to the LA, so we use the balloon, over the wire balloon for the peripheral artery. So I usually use a 7 millimeter or 8 millimeter over the balloon. Yeah.
7 or 8 millimeter balloon you use. Okay. And is it sufficient for the SGC crossing?
Yeah, I think so.
Okay.
Well, yes. Apart from the dedicated RF needle, sometimes if you don't have the RF needle, you can connect to a diaphragm, all right, with your ordinary needle, and then use the diaphragm to assist you to get the puncture needle across the thick or fibrotic atrial septum, and then exchange your guide wire. I think balloon dilatation is very important, all right? Sometimes you can use a stepwise balloon. Sometimes you use a PDCA balloon, all right? Few centimeter and then gradually upgrade. Because you'll be too forcefully push the guiding catheter inside, and sometimes it may tear. It may result in an unexpected severe tear of the atrial septum. So cautious stepwise balloon dilatation, and then, well, I fully appreciate that. Eventually you'll get the guiding catheter across.
Yeah, I think stepwise balloon dilatation is very important. We have one experience to tear of the septum during the procedure. So finally, we closed the AS device.
It was closed with the ASD without pericardial effusion. You mean that you use the AS device for the
iatrogenic ASD.
Oh, wow.
14 millimeter.
Yeah, 14.
And just another trick, if you are struggling to cross the septum with the needle, is to use, if you are working with an excess needle or something that is quite sharp, to use the back end of a PTCA wire. And then this is going to help you to get across, and then you pre-dilate.
Then which kind of PTCA, anything?
Anything,
PTCA
because
wire?
the back end of any wire is quite stiff.
Like
it's straight and stiff.
Yeah. Thank you for sharing the valuable tips. And we now pass the LA. And can you please share the pressure curve in the LA? Yes, this is the pressure curve from the SG sheet that shows the prominent V wave with a peak of the 34. His blood pressure is the 120, and this is quite the significant V wave is seen. And then I will begin the procedure. This is XW, as we discussed before. We would clip the most significant regurgitation with the wider clip. And considering the 5.0 square centimeter, and the feature I would consider the next clip or not. And I've heard very interesting the result from the Japan that about the small MVA, that the clip in small MVA from Kubo. If it is possible, can you please share a small opinion about the clip in the relatively small MVA?
Yes, so I think that the AGM patient has I think a small body and small MVA. So our OSHA mitral data, so I think the 30% of the patient has a MVA less than 4. Yes. And,
30%?
Yeah, 30% of the patients are less than 4. But actually the outcome is similar to the outcome, and the MR reduction is similar to the compared to the patient with MVA over 4 square centimeter. So I think just only the small MVA is not just risk of the procedure failure. But I think in this case, the MVA is 5 square centimeter is not so small.
Yeah,
but I think the leaflet is not so smooth and little bit rigid. And the opening of the commissure site, A1, P1, and A3, P3 is not so opened. So that's why I will put only one XCW in these patients.
So now you inserted the device, the XTW or XT now?
This is XTW.
XTW, okay.
Yeah,
so
the wider clip for the
wider
first
clip.
device.
Okay. So now, commentator, so where is the most appropriate clip in this case at first?
We think that the most
tethered
tethered area is the central medial region. Can you please show us the echo image again? Okay, yeah.
Yeah, but can you, let's take the biplane image. Yeah. Or central medial.
Yes.
Central and centrolateral. Because of the dysfunction of the posterior medial papillomas, the medial part of the mitral valve should be tethered more, presumably. Yeah.
Okay, central medial. Now, staring down, and you go.
So making a good axis is a little bit difficult. Yeah, the good AP, the anterior posterior image. And how about the, is the image good, or shall I wait some more?
Let me check. Wait a minute.
Yeah, I will wait a minute. Yeah. Because in the AP image, it looks that the clip is that heading to the anterior flat.
Yeah.
We need some more
Anterior
adjustment
yeah.
for that.
Yeah.
Yes. I get some more
Anterior
adjustment. Yeah. To add the more posterior.
Mm-hmm. More central.
How about this?
Yeah, centrolateral.
Okay.
Let me show you the picture and that.
I guess this would be medial dive, as you can see in the floor.
Yeah, and dive,
It's
and
very
dive.
medial.
Right, you're right.
Yeah. Okay, I'll adjust. How about this? Can you please show the image? Okay.
Okay.
Oh, very medial. Yeah. I think that taking a good the good bicommissural view for this patient looks a little bit difficult.
Yeah, that is good.
Anterior dive?
Yeah. Okay. Yeah, slightly anterior directed.
Yeah. How about this?
Yeah, trajectory.
Do you have any still any minus on the guide shift? Did you release
Yeah, I have some minus.
Don't you want to withdraw it?
Yeah, I will reduce the minus. Okay. I reduce the minus. Now it's nearly zero. Yeah. Okay. But it is heading toward anterior.
Anterior.
Yeah. So I give a little bit minus for this situation. 사이플레를 이렇게 잡으면 되나요? 예, 지금 클립이 뭔가 제대로 안 잘려 보이는데.
다시 한번
예, 3D를 한번 다시 보여주십시오. Yeah, we will check the image again. I think the image is not very, the axis is not so good.
Yeah, this.
Because when we have a look at the fluoro, it means that you are it's quite posterior, in fact, with the guide shift.
Yeah.
If you correct that, you're gonna get
Dr. Wang, this is good.
more of a regular
That is good.
trajectory. Yeah.
Okay.
And then you
Yeah. How about this angle?
Yeah, anterior directed and slightly L dive. Yeah, anterior posterior is good. Please use abnormal.
I think you need a more minus knob.
Yeah, I lose the minus, I decrease the minus, but it doesn't work. So this is increasing the minus,
Yes.
and the angle looks better. It does a little bit more M,
Anterior.
and here.
Okay, looks good.
Just a little bit too much tension.
Yeah.
How about this?
Anterior posterior is good. Yeah.
How do you
Okay,
like
okay,
tension?
okay.
The
Yeah.
trajectory.
Now it's good.
How do you think about this trajectory, the panelist? Because I do not 100% satisfied with the septal puncture position, but we could not find other, so we should adjust here.
Now it's good. Yeah, you
그 컬러 한번 보여주실래요? Can you please show us the color?
Yeah.
You prefer here? Click. Then I will check the trajectory again. Like this. Is this a little bit M dive?
Oh, I don't think so. Good. That was good.
Then I will open the clip.
Okay, let me check the 3D orientation.
If you have any opinion or some comment, please guide us.
Counterclockwise.
It seems, do you, what degree of M do you have on the system? Maybe you could add a little bit more.
Yeah, I can do more.
Counterclockwise, please.
Yeah.
And then if it brings you more medial, you're going to push the entire system together.
Okay.
More medially and then counterclockwise.
Yeah, M and then correct with the...
Yeah, better than
I get
before.
more
Yeah, good. That was good. Let's move to the... Okay. Let's take the gripper.
Yeah, it got better, I think. Yeah. And this is gripper. Anterior gripper is well seen. And posterior gripper, can you please show us? Yes, it's well seen. And the dotted gripper is the posterior.
Posterior.
Yeah. Okay. 위치 다시 한번 봐주실래요? Can you please check the position, target, reflect? Is it
Please
good?
check a trajectory again.
Yeah.
Yeah. Push and pull.
So your M is to start central, A to P2, and to see the what the outcome is going to be. And usually that's a good strategy for functional mitral regurgitation. You start central and you...
central medial, we are...
Yeah, central medial, first target.
Here.
Yeah. Let's check the color. Yeah, right over there.
Here is the target. Shall I go more central or flip here?
Oh, now it's good.
Okay, then I will move in. The clip is rotated.
Oh,
Yeah.
rotated.
It did rotate a bit.
Let's take it.
So this case is a very unusual because too much posterior puncture, maybe. That's the reason why that kinds of, some...
That's right.
strange alignment in
clockwise, please.
for the procedure,
Rotate, because here is the 8 feet, so I will rotate a little bit more.
Yeah, clockwise.
Yeah, you need some clockwise,
Clockwise.
A little more. Clockwise. Okay. 6, 12. Okay. Let's take the color again. I think you can move more centrally from here.
You want more central?
Yeah.
Okay.
Slightly.
I will
a
move
little
gently. Can you please show the without color image?
Okay.
Yeah. Okay, I moved a little bit. Yeah. Do you like here?
Yeah. I print that out.
Anterior rib is not on.
Yeah, in this image, it seems to be M dive.
Then
the exact conventional view can be seen when I use two hands simultaneously.
Yeah, is the left side view is okay?
Yeah. That was good. Yeah, M dives.
Still M dive?
Yeah. Yeah, better than before.
How about the position of the clip?
So
is it too medial?
So in this
Yeah,
patient, FMR
let's
patient.
move.
So and they are a
more
little bit
central.
tethered the mitral reflex. So a little bit more close. Grip is better, easy to grasp.
Yeah.
Because as you are at 180, maybe a little bit less than that will help you to capture the leaflet.
Yeah,
it is better. Yeah, thank you.
It is better. It looks better. And how about the position? The more move to more central or
central,
stay
please.
here?
Central, please.
More central. Yeah. But this, the image is not stable. Okay, I will wait. How about here? I moved a little bit.
Yeah, let's take the 3D. Yeah, counterclockwise, please. To rotate it.
Rotate a little bit counterclockwise.
A little more.
Yeah. How do you think about this?
Yeah, a little more.
More, yeah.
Okay, yeah.
It looks okay.
Yeah.
How about this position? Move more central or? Yes, good.
Yeah, slightly more central.
More central?
Yeah. I believe.
Can you please show the
Color,
plane without color? Yep. Because it does not move well. Yeah.
Yeah, you posture plate should be on more.
Yeah. I think it would be better to go out and do it again.
Yeah, and dive.
Yeah. I will retreat?
Yeah.
After you go to the atrium, could you check how deep is the is
나갔다
the
다시 오자.
sheath?
다시
Because it looks like the sheath is very deep into atrium, and it gives you an approach that requires a lot of M and then may produce the diving. So maybe it could be possible to withdraw some of the sheath and then release some M, and you will be more.
Yeah, we need the start begin again with the start. The beginning. Okay. How do you think about the? Let's check the trajectory again.
Yeah.
Yeah.
Exactly. Anterior directed.
It's very anterior directed.
So you still have an anterior trajectory, but it's difficult based on the anatomy of the atrium and the puncture site. So maybe your strategy could be a little bit modified and start with the anterior, capture the anterior, grab the anterior, and then move to the posterior.
To posterior. Okay.
It may be difficult to get a simultaneous grasp in this situation.
Yeah.
So the minus knob is a maximum in this situation?
Not maximum yet.
Yeah, I think that you need a more minus knob.
More maximum, yeah. Here is the maximum. We are in maximum here, like this.
Yeah, Dr. Kang, now it's good.
Yeah.
Yeah.
Like this. How about the M and L?
Oh, good.
Trajectory?
That is good. Yeah.
Okay. And then here, let's check again.
And I would still add a bit of M just to be more
Yeah.
perpendicular.
I agree. Yeah, slightly M dive, slightly M dive.
It's gonna be better.
Okay. How about this?
Better than before.
Yeah, check the trajectory again, like this. It
Good.
will be
Now
better.
it's good. Now it's
it's
good.
better.
Yeah.
Yeah. The maximum M and the release the M. Maximum minus. And can you please show the 3D again?
Okay. Yeah, now it's good.
Okay. And check the
grip
again.
again.
Okay. We could
Both.
see and the
Posterior
posterior
is that.
Yeah. Okay. Let's move on. Okay. 포지션 한번 다시 확인해 주실래요? 여기서 더
now it's good.
들어갔는지.
Better than before.
Okay. Go in. 네?
Slightly M dive.
Still M dive.
Yeah, when put into the LV.
Okay, then I will release more M. How about this trajectory?
Good. Okay.
We're going.
Yeah, good. Better than before.
Catch the anterior
Okay.
first.
Let's take the.
이거 잘 보여주세요. 이미지가 지금 Can you please show the biplane again? Okay. Is the posterior leaflet in?
Maybe you can now open a little bit more.
Yeah.
Slightly more. Yeah, just a more. Yeah.
Yeah, let's take the orientation.
But it's 2M. Too much media.
Okay. Yeah. Just a little comment. In this situation, first of all, we need to make sure that the struggling is appropriate. It is not. And this is also in terms of safety, because every maneuver you are going to do will probably respond in a funny way. So that's. But also there are two strategies. One, I agree with Didier that one is to capture the anterior leaflet and then move posteriorly just to get the other one. However, if you go just a little bit posterior now, adjusting your view, you may actually take both together. But the straddling is not appropriate, so we need to go back to the basics. And first of all, I will go for a little posterior way because the anterior leaflet is wide. So the high chances to get it anyhow. So instead of going for the more complex strategy, as Didier suggested, I would just start from the simple one. It's too open now. So you need to give some kind of invitation for these leaflets, otherwise it's not gonna work.
Okay. Thank you for your opinion. And then I will close a little bit more.
Yeah, slightly in type. Yeah, it's okay.
How about this position? Is it good?
Yeah, now it's good. Yeah, let's take the color. Yeah. Okay, let's take a 3D.
The anterior is not in.
One more.
It will show the 3D. Okay. Oh,
yeah, let's take
I'll
3D. Maybe rotate it.
Yep.
Counterclockwise press.
A little bit. Less than 10 degrees.
More, a little more.
Yeah.
More.
Okay.
One more. Okay. Yeah.
Anterior leaflet is in.
More posterior.
Fine.
So if you have, it may be more complex, but if you have the anterior leaflet, go and grab it, grasp it, and go go to the posterior.
Yeah, actually independent grasping.
Because simultaneous grasping is going to be tough.
Yeah, so fast
you may do it, but it's
anterior leaflet length enough, so
yeah, posterior
first
is good. Enough.
Do you recommend the independent gripping for this situation?
Yeah. Now ML is good enough to grasp.
Yeah.
So grasping and go a little bit into LV.
Yeah, anterior grip is down.
And then go posterior.
Go posterior and close a little.
이미지 좀만 더 잘 보여주세요. Yeah.
Close grip a little to get PML.
And then you're going to get it.
Come back.
A little bit more.
Now.
How about this? And now?
A little bit. And go up. Yes.
Oh, that's good.
Great. That's good.
Yeah, grip is down.
Yeah, it's okay. Looks okay.
Oh yeah, looks good. Yeah.
How about the
PML? Good.
Looks good.
And before you fully close, just make sure that you are happy with the position in the bicommissural view.
Yeah, it's just 120 degrees. Let's see.
Slightly end dive seems to be.
Is the posterior press enough or not?
I think that you should check that, how much posterior leaflet in the posterior grip arm, because I'm not sure the leaflet is actually enough or not.
No,
is it enough?
Enough.
Yeah, you can.
Enough.
Yeah, you can once the grip up, drop the grip up, and check the posterior leaflet.
You can put up a little more.
Can you
Then
please show the echo again? Then I
Yeah.
will try a little bit more.
little bit more, maybe.
Yeah. With the grip up.
Yeah. And
A little bit.
More posterior.
Yeah.
Yeah, better than
nice section,
Yes.
yeah, not different from that. It seems to be better than before.
Yeah, I tried.
Yeah. The insertion is very good
Yeah,
actually.
we tried for a
Posterior.
little bit
Yeah.
more. Posterior would be a little bit more in.
Yeah, seems to be more.
Yeah.
And
But not as much as we could not fully grasp it.
and as Didier says, you should check the orientation, grip orientation in the 3D again before the free closing.
Yes. 3D도 한번 봐주시고 컬러도 한번 보여주세요. Let's check the grip and grip orientation.
Slightly counterclockwise rotated maybe.
다시. Is it a little bit rotated to counterclockwise?
Yeah.
Okay.
But sometimes it happens after the CGA procedure.
Yeah. Then let's try it again. It does a little bit rotation of the clip. 3D 다시 한번 보여주세요. Yeah. Yeah, this is 3D again. Then do we need a little
Clockwise.
bit clockwise rotation? Gently.
Gently, very gently. A little more. A little more. Okay.
How about this? Yeah.
Oh.
A little more, please.
A little more?
That's okay. Yeah.
Let's see, it has moved to a little bit medial.
Yeah, it's endive.
In this situation, I think a PIP application of PIP is somewhat helpful because improve the coaptation and move more lateral position.
Yeah.
So I think it's one of possible way to to the procedure.
Okay, we have
slightly
requested
endive.
to increase the PIP pressure a little bit more.
Better than before. Yeah, let's take 3D orientation again,
Yes.
and then do you use independent grasping right here?
Oh yeah. If feasible, I will try. How about the clip orientation here?
Oh, yes, good.
Yeah, taking a good image is difficult. Yeah, okay. I will try again. So anterior flip, grasping.
Yeah, you should go load the anterior and go back
Yeah.
to the posterior.
Like that, grasping a little bit. Let's see. Oh yeah, here.
Yeah, insertion is good
And
anterior.
then move a little bit posterior. How about here? A little more?
More. Not yet. Not yet.
Here.
Oh, better. Yeah. It's okay. Yeah. How about anterior? Prominence anterior.
Anterior was in.
Loss of incision.
Yeah.
Do you think?
I would optimize now a little bit the anterior just to make sure that you have enough.
Yeah, okay.
Imagine more with anterior.
Let's take orientation again.
예, 이미지부터 다시 보여주세요. 2D. 바이플레인. 바이플레인 한 번만 더. 예, 오케이. 안테리어 리플렛.
Yep.
다시 볼게요. 오케이.
포스티어는 잘 들어갔는데.
리플렛 잘 보이나요?
It's good.
Okay.
It's good.
Okay, I cut. Do you need more?
No, it looks good now.
Yeah, looks good.
And this is 120 degree.
Yeah, let's take orientation. Yeah, orientation looks good. Okay?
Okay, and how about the color?
Color.
It's nice.
Yeah, nice
So
position.
I would give it a
Yeah,
try.
but please close the clip.
Close
let's
it, and then if you
from
need
the-
a second one, you can.
Yeah, okay,
you
I
can
will
adjust.
close a little bit more. It's 60 degree. And I'll try to fully close.
I think you
Yeah,
need
you
the
lost-
posterior
you lost
reflex.
it.
Oh,
You
posterior,
lost-
like
you lost the
posterior.
posterior.
Yeah, posterior.
Oh, you lost the posterior. Yeah. Not easy.
Yeah, Dr. Kang?
Yeah.
Just keep going. Dr. Song just finished the procedure, especially tricuspid position. So I think we just check and final, and then come back again.
Okay, thank you.
Yeah.
Okay, Dr. Adams, thank you very much. Dr. Adams, thank you very much. So already finished the tricuspid procedures?
Yes.
Okay, so please show the angiogram and the echocardiographic result.
Okay, sure. Now on the screen, I'm left hand side is weighted, so now you can see
Hi, friends.
his face. So on the images, that is after the first clip, you can see that we received the only trivial TR was left. So after the first clipping, we can see that the shunt has already diminished, and now it's only left-right shunt.
Great.
Yes. So therefore, we go for the second clip to improve the long-term durable effect. So it's a Clover technique. So after second clip, we don't see any residual jet, residual TR, and then we see the shunt, and it's purely left-to-right shunt. So it also increase the left-to-right shunt. So we successfully reduce the eye pressure. By abolish the TR.
Okay, great. Thank you very much, Sawyer. And yeah.
Thank you.
Congratulations.
Thank you very much.
Okay.
Okay, I'm still doing the independent grasping. It's a posterior. How about here?
Yeah.
Some more?
Maybe lots of.
Yeah, you can do more.
그 컬러 한번 다시 보여주겠어요? 더 잘 안 가서. It does not move so much. And check the 60 degree.
Oh, yeah, better than before. Yeah, let's take orientation right
Yes.
here.
I think you lost posterior reflex already.
Yeah, looks good. Go ahead.
Is the grasp okay? Okay. Color, please. Okay, I'll close.
Yeah, posterior looks out.
Oh. The posterior okay? No.
I don't think so.
It's good.
Yeah.
So,
How about the posterior?
Lots
It's out. Okay.
Dr. Kang,
Yeah, out.
I have one
Posterior is out.
suggestion.
Yeah.
And you should move to little, how do you move to lateral side? Because in this side, there is a dense cord in the posterior side.
Yeah.
So when you try to catch the posterior leaflet, the tip of the clip pushes that cord, and the posterior leaflet made car-like shape, right? So that makes that cord makes you hard to grasp the posterior leaflet. So in such case, I move little lateral.
Lateral.
Yeah. How do you think about it?
I think good idea. Yeah.
Okay.
And also,
lateral 먼저 잡고
You mean the more central?
Yes.
I mean more center.
Yeah.
Yeah, I agree. Yeah.
Then moving a little bit more central. How about here?
Let's.
So, Dr. Kang?
Yeah, more laterally.
Yes. Yes, please.
So, you are now 2 minutes. Okay. Please procedure.
Okay.
Please
Thank you.
procedures.
Dr. Khan, so if you want to good posterior leaflet insertion, I think you have to advance the clip a little bit to the
Yes,
LV.
I think so.
Yeah.
I agree.
And go to the posterior leaflet.
One more try, right?
Yes.
This side and this side.
Can you please review the 3D angle? Is it okay?
Yeah, okay. One more.
Okay.
Yeah, much rotated. Clockwise, please.
Here it's a little bit dangerous, but I'll take care. 이 정도.
One more. A little bit more.
예, 여기서 한번 보시죠.
Yeah,
예.
여기서 한번 봅시다. Yeah, you may think
I think the
compromising.
image is not
Yeah.
good, and I think there is some entangling. So I will stop here.
Yeah.
And I will
Reverse the
release.
clip.
Yeah. I
Yeah,
feel
posteriorly
some
flat,
resistance. Yeah. Okay, now it's okay.
Oh, now it's okay.
Okay, now. Okay.
Oh, yeah, that was
Okay.
good. That was good.
Now,
Yeah,
okay.
without independent. Yeah, let's
How
take
about the
orientation
color?
again.
Yeah, color and orientation.
Yeah,
Yeah,
orientation
it's
is
okay.
good.
How about the
Let's
color?
take the color. The just.
I think it's much better.
Yeah, it's
and
good. It's
I think
good.
I can grasp it simultaneously.
Yeah.
Yeah. So 보여주세요. Like this.
여기 아주 좋은데.
Yeah. And this is.
Yeah. It's posterior insertion is good.
Can you please check the echo, the Doppler? Yeah. Okay. And I will try. Okay. Can I close?
Yeah.
Yeah. Okay. I'll close it.
Oh, posterior insertion is good. Yeah.
Posterior is much better.
Great. We did.
So releasing the pressure, releasing the tension, and
We are lucky
Just
to see
trigger
you
them out.
as success.
yeah. Oh, it's in 2 minutes. Can you please check the echo and the grasping more thoroughly?
Yeah, the reduction of the MR is very good. Let's take the primary venous wave pattern.
5분? 2, 3분? 알았어요.
Oh, S wave appeared.
Okay, how about the stability? Because
Yeah, I think the steerly
the panel
medially
tilted.
tilted.
Yes, it's the medially rotated.
Any
How do you think
reduction in
about
the
this?
airway
Stability
pressure?
is very good. The problem is the clip grasp just media directed.
Then how do you think about the situation, the panelist? About the medially headed the clip. Will it change or?
Could you show us the gas station color, please?
Yeah, color, please.
Color, yeah.
Very good.
Yeah, very nice.
How about airway pressure?
Airway pressure is the peak is the 29, a little bit decreased, but still there is some free wave.
Yeah.
Yeah.
Venous
But
pattern much
that will
improved.
be related to the decreased compliance of the LA, it might be.
Sometimes LA pressure is insensitive, so systolic flow reversal disappears. So, Do-Yoon is Joo-Yong, so I think that you can implant a metal clip here.
If then Kim, do you agree? Okay.
Let's vote.
Then
Yeah.
it's a little bit medially located, but
I think
The insertion is very good.
Yeah, you grasp several times. I think there is some injury.
Yeah.
So I think
damage
just
in
release
the-
and then check again.
Yeah, let's
It's
try.
better too.
Yeah. Very good insertion.
it's not where.
How about the gradient?
How about the gradient?
Gradient?
Yep.
I think just 2 more something.
좀 올려주세요. Yeah. Can you please measure the gradient?
2 more something.
Okay,
Two.
it's just 2.
Oh, great.
Then, okay, I will remove the long line. I think that the trial is that will be not good for the patient.
Yeah, can damage the leaflet.
Yeah.
We tried 3 times.
And the clip is good. RAU2.
So what about color?
Yeah, color.
Yeah,
too.
color.
Yeah, color. 1,
Very good.
2,
Oh, very nice
Yeah.
4,
results. Thank you very much.
6, 7, 8. Okay, I will remove.
Oh, you can remove the grip now?
Just wait.
Okay.
1 minute.
Yeah, already removed.
1 minute, okay.
Yeah.
Oh,
can see
already.
Usually
Okay.
patient is getting MR, the
There's
central
some-
medial point is critical.
Yeah.
Yeah.
Oh.
But there is some movement of the
Oh,
clip,
slightly
the
increased.
media.
The clip stability is very good.
How about the How about the MR degree, residual MR?
Mild.
In fluoro,
Yeah.
How
yeah,
about
consider-
3D image?
Yeah, let's check 3D again.
Medial range, I think.
yes, it's a little bit medially located.
This,
Yeah.
yeah, I think it is medial range of the
Yeah.
P2. But there is no SLDA now.
Yeah, no SLDA. And the
Yeah.
clip looks quite stable. And the color is from the lateral, the medial side.
Medial
Oh,
side.
medial side.
Okay. Yeah.
Okay, thank you very much. So, we presented all the 2 cases of the mitral grip. One case is from Taipei and the with the grip, and this case is functional MR, very difficult to grasp. But finally, Dr. Hahn successfully
image is very good.
plated.
Yeah,
Okay,
it's really-
thank you very much for attending this session.
Thank you.
Thank you. ありがとう。